Good afternoon. I'm Ajay Aggarwal. I'm the Clinical Director for NATCAN. That's the National Cancer Audit Collaborating Centre. You're warmly welcome to our webinar today, where we're presenting the key findings from the State of the Nation reports that were published in September of this year. We are presenting on 6 national cancer audits based in England and Wales. Those are the reports of kidney, ovarian, pancreatic, non-Hodgkin's lymphoma, and 2 breast cancer audits, primary and metastatic. We've got 6 of these talks. Each will be roughly 20 minutes, 15 minutes for the actual presentation, and then we'll have 5 minutes for questions. I do urge you to please send any questions during the presentations through our question and answer session, and I'll pose these to the presenters. It will be approximately 2.5 hours. We're expected to finish at 4:30. We do have a 15-minute break at approximately 3:05, which will be for 15 minutes. So you can take a breather or get a cup of tea, but I promise I think it'll be a very engaging session. There's a lot of excellent content here, and for 6 new cancer audits, really setting or paving the way for the next few years, improving processes and outcomes of care. Next slide, please. I just wanted to give a bit of context about the National Cancer Audit Collaborating Centre. It builds on approximately 15 years of work, and obviously it's not a centre without a complicated organogram, but what it really shows is that we have a number of structures here. First of all, we're with 10 cancer audits. So we build on established audits in lung cancer, prostate cancer, bowel cancer, and esophageal cancer audits, and they'll all be reporting as well in September. They've got ongoing reports as per previous years. Within each audit, we're a clinical and methodological collaboration, so as well as clinical leads chosen by professional bodies, we also have senior methodologists, clinical fellows, data scientists, and audit managers. We feed up to a NATCAN board with representatives from NHS England, Macmillan, the Royal College of Radiologists, and the National Disease Registration Service, amongst others. We also, within all our groups, have clinical reference advisory groups and patient and carer panels. So we need to be informed as to what are the relevant questions to ask to be able to implement best practice and care and to improve the outcomes of experience of patients. Next slide, please. We're going to start off with the initial presentation by Mayne. She's one of our data scientists working with the National Kidney Cancer Audit, and we look forward to hearing this. Please go ahead, Emily. Thank you.
Thanks very much, Ajay. Yes, so as Ajay mentioned, I'm a data scientist that works on the National Kidney Cancer Audit, and I'm going to give you a short presentation outlining some of the results from our State of the Nation report that was published recently. I'm going to focus on key findings and highlighting the recommendations that we made. Next slide, please. So as a brief introduction to the audit, so the National Kidney Cancer Audit has been set up to evaluate kidney cancer care delivered in NHS hospitals across England and Wales. It aims to help NHS organisations to benchmark their kidney cancer care against measurable standards and to identify unwanted variation in care by providing regular and timely evidence. We also hope to provide tools to help services improve quality of care for people with kidney cancer through quality improvement initiatives. Next slide, please. So who are we? So the National Kidney Cancer Audit is one of 10 national cancer audits being delivered by the National Cancer Audit Collaborating Centre, so NATCAN. And NATCAN was established as a National Centre of Excellence in October of 2022, with the aim of strengthening NHS cancer services by looking at treatments and patient outcomes across the country. On the right-hand side, you can see the kidney cancer team. Next slide, please. So alongside, just before our State of the Nation report was published, we published our quality improvement plan. That's a document that I urge you to go look at on our website. And in that document, we outline our 5 improvement goals. So our first improvement goal is to increase regional equity in timely access to evidence-based kidney cancer services. Our second goal is to increase the use of renal tumour biopsy. Our third goal is to expedite treatment for people with localised renal cell carcinoma, a potentially high risk for recurrence. For example, T3 plus tumours or 10 centimetre plus tumours or N1 tumours. Our fourth goal is to increase the use of surgery, if medically appropriate, for initially localised renal cell carcinoma at high risk of progression. while reducing the use of unnecessary extensive radical surgery for low-risk renal cell carcinoma. And our final goal is to increase the use of evidence-based systemic therapy in eligible patients without increasing severe toxicity. Next slide, please. So you don't need to take this slide in because I appreciate that it's extremely busy, but this just provides you with an overview of our performance indicator results, which were in our State of the Nation report. I'm now going to go through each of these in order. Next slide, please. Okay, so our first performance indicator, which our performance indicators follow on from our quality improvement goals. So the first one is the percentage of people with kidney cancer who have a record of an MDT meeting. So for England, the national percentage we found was 82%, and for Wales, the national percentage 99%. We think the difference between these national percentage partially reflects data completeness. So we think that for England, data completeness accounts for the slightly lower percentage than our clinicians expected. Data completeness is extremely important to our audit, and is a big focus in our quarterly reports, in which we provide trust level data completeness information for a number of key data items for our audit, and the other audits do this as well. To provide you with a bit of context on this result, so the Scottish audit has set a target for 95% of patients having an MDT meeting, and they surpassed this in 2020, reaching 96%. Then moving on, next slide, please. Our second performance indicator is the percentage of people with kidney cancer who are consented for a clinical trial. We weren't able to measure this in Wales for the minute due to not having the appropriate data, but for England, the current national percentage we found was 2%. So this is for 2019 to 2021. This is quite similar to the result that the Kidney Cancer UK Accord report found. So they found that clinical trial participation was 2.7% in 2017 to 18. And interestingly, they delved deeper and they found that the clinical trial participation varied by M stage. So with nearly 7% of M1 renal cell carcinomas having evidence of trial participation versus 1.8% of stage M0 renal cell carcinomas. Next slide, please. Our third performance indicator was the percentage of people with a small renal mass, which we defined as less than or equal to 4 centimeters, and the percentage of those patients that have a biopsy. So we found that for England, 20% of people with a small renal mass we had a found record of a biopsy. Unfortunately, we were unable to calculate this for Wales, but we found the English result very interesting, and it inspired our first recommendation. So the recommendation is to increase the number of people with a small renal mass who receive a renal mass biopsy to confirm the histological diagnosis by improving availability of timely diagnostics. We do appreciate there's many barriers to implementation of renal mass biopsy, including duration of diagnostic pathway, information provided, perceived usefulness, access to and capacity required, confidence in healthcare professionals, and experiences of prior biopsy. Next slide, please. Then our fourth performance indicator was percentage of people with T3 plus and or 10 centimeter plus and or N1 tumor, as long as they were M0. So the percentage of that cohort whose radical nephrectomy is within 31 days of diagnosis. So for England, we got the national percentage was 69% that we found in our data. And this is a little bit off. So NHS's England's objective for the 31-day treatment standard is set at 96%. So what we found was quite far from that. Unfortunately, we couldn't calculate this for Wales at the minute, but we hope to in the future. These results inspired our second recommendation, which is to review pathways for higher risk renal cell carcinoma to understand system level delays and ensure providers treat these people within 31 days from decision to treat in England and 21 days in Wales. Next slide, please. Our fifth performance indicator was the percentage of people with a T1b to 3 NNE M0 renal cell carcinoma, and this was we actually narrowed this in Wales to T2 to 3 NNE M0. So it's the percentage of these people who have a surgery. So for England, the national percentage we found was in 76%, and in Wales it was 80%. To put this into context, Kidney Cancer UK Accord found that just under 73% of T1b to T3 renal cell carcinoma underwent surgery. Their dates are slightly earlier than us, so they were looking at 2017 to 18, whereas we were looking at 2019 to 2021 for England and 2022 for Wales. And this inspired our third recommendation, which is to identify and address reasons why people with kidney cancer, stage T1b3, NNE, renal cell carcinoma are not considered for surgical treatment, and increase the number of eligible people. Next slide, please. Our sixth performance indicator is the percentage of people with T1A, N0, M0 renal cell carcinoma who undergo nephron-sparing treatment versus radical nephrectomy. So yeah, it's the percentage of people with T1A, a tumor, who undergo surgery. What percentage of those are nephron-sparing instead of radical? So we found for England that it was 67% of patients. Unfortunately, we couldn't calculate this one for Wales, but we hope to in the future. How does this compare to Scotland? So Scotland, their proportion that was nephron sparing was just under 84% in 2020. We were looking at 2019 to 2021. There's an interesting paper on the right-hand side. There's a graph that shows, the paper's also referenced at the bottom of the slide. It's found a relationship between hospital volume of nephrectomies, and with increasing hospital volume of nephrectomies, increasing proportion of those being partial nephrectomy. Our results inspired our fourth recommendation, which is to ensure that people with kidney cancer, stage T1A, N0, M0, renal cell carcinoma, are discussed in specialist multidisciplinary team meetings and offered nephron-sparing treatment. Next slide, please. Our seventh performance indicator is the percentage of people presenting with M1, so metastatic renal cell carcinoma, who have initial systemic anti-cancer therapy within 12 months of diagnosis. So for England, we found that this was 48% of metastatic patients between 2019 to 2020. Actually, this is 2017 to 2021. And in Wales, it's we find 57%. Compared to some what other studies have found, so the Kidney Cancer UK Accord found very similar to us. So they found that just under half of metastatic RCC, so just they got 47% received SACT up to 1 month prior and 1 year following diagnosis. And these results inspired our final recommendation, which is to ensure people diagnosed with metastatic renal cell carcinoma are evaluated by a medical/clinical oncologist with expertise in renal cancer management and receive systemic anti-cancer therapy. Next slide, please. And our final performance indicator that we reported in this State of the Nation report is the percentage of people with kidney cancer who die within 30 days of starting SACT treatment. So for England, we've got 3%, and it's that was from 2017, it's meant to say, to 2021. And for Wales, we got the same percentage, so 3%, and that was in 2022 for Wales. So that's not too far away from what the Scottish audit found. So they found 4.5% 30-day mortality after SACT in 2022. Next slide, please. Oh, so as a brief overview of my presentation and what we consider the key findings. So the percentage of people with a T3 plus tumor and or 10 centimeter plus and or N1, as long as they were M0, whose radical nephrectomy was within 31 days of diagnosis, is much lower than the NHS England objective. As I previously said, so we found 69% in England, and the NHS England objective is 96%. Another key finding we thought was the percentage of people presenting with metastatic RCC who have initial systemic anti-cancer therapy within 12 months is very varied depending on provider. So we find sort of 15 to 81%. It was the range for providers in England. But we are working with NHS England to help increase the percentage of people who receive SACT, as they have identified this as a real area of interest for them. Next slide, please. And thanks very much for your attention. As I said on the slide here, we greatly appreciate any feedback or queries about the audit. I will try and answer as best I can. If we need more of a clinical input, then we will get back to you in the future.
Thank you very much, Emily. Fantastic. Can we just stop the slide share a second, please? So we've got plenty of time for questions. So I think the first one would be very helpful as giving background is actually how were the performance indicators considered? What made us decide those performance indicators? What was the process?
Yes. So it was that was a very big part of our sort of setting up of the audit, was making sure that we selected the appropriate performance indicators, because we're trying to set up these performance indicators that we then report year on year. So the sort of key criteria for us were, and for all of the NATCAN audits, were that they were measurable, so that they can be like a basis of credible feedback about performance. So that was making sure that we had the appropriate available data, and that we'd be able to report it in a valid, reliable, and fair manner, and that the performance would be able to be attributed to a specific unit. So first point was sort of making sure it's measurable. The second that was really important to us was making sure that it was an actionable performance indicator, so that feedback translates into action, which will hopefully then improve care. And then the third aspect for us was that it's something that is improvable, so the actions can have the desired effect on patient care. So those were the three criteria. And so yes, we did have a long list of potential performance indicators, and then with this fantastic spreadsheet that our methodologist created, which then assessed each of the performance indicators against our criteria and helped us whittle down and then get down to our 10. Well, actually I think we had 10/11, but performance indicators.
Yeah, it was a long deliberative process, wasn't it, with the clinical reference groups and patient panels and looking at the evidence. And there has been a question around where was the evidence for some of the performance indicators, and we'll get back to you offline regarding that, Haytham. A question that has come up, which probably many people are thinking, is that the dates of the data that we're presenting. And there's been a question a couple of times from Lee, particularly asking around more recent 22 or 23 data. Do you mind just giving a bit of information around the data that was used for these performance indicators, and maybe something around the rapid registration data we're using for our 3-monthly reporting?
Yes, absolutely. So for our performance indicators, our audit, the kidney cancer audit, used the gold standard data, which is called the National Cancer Registration Data Set. We thought that this was the most appropriate data source for our performance indicators, because it had the other option that Ajay mentioned is the Rapid Cancer Registration Data Set, which does provide more recent data. So we did have that data available to us into patients diagnosed in 2023. However, we opted for the gold standard data, particularly for this first iteration of the report, because it had a better completeness of really key data items for us. So TNM, is super important. You'll have seen throughout my presentation that so many of the cohorts that they were required for the performance indicators and how they were defined required TNM, because we were looking at, for example, just T1A patients or T3 plus. So the gold standard data had better completeness of this TNM, which is very important to us. There's other audits that potentially would touch on that today, who were able to use rapid data for their performance indicators, because, for example, they were able to use, in the rapid, there's good completeness of a variable called stage, which for some audits that's perfectly good to use, whether it was stage 1 to 4. But for kidney cancer, we can't really use stage 1 to 4 because stage 4 includes patients. It doesn't really tell you whether they were N1 or M1. It's not specific enough for kidney cancer.
Thank you, Emily. Yeah, so depending on the type of question, we can use more recent data, but actually where we want confidence, particularly on the staging, we've used the gold standard data set, and that will vary across the audits. There's been a very specific question around your performance indicators 15 and 16, and particularly around surgery, whether this included ablation, radiofrequency ablation.
Yes. So is that the percentage of T1B to 3 patients who have surgery?
Yes.
And then, so that, yeah, the percent for the performance indicator 5, we only included patients that have had surgery. We did not include ablation, because we were particularly interested in looking at, of the patients who have surgery, what proportion of them are partial nephrectomy as opposed to radical nephrectomy. That was the specific answer we wanted that was the specific question we wanted to answer. And then for the next performance indicator, which was the percentage of people with T1A who undergo nephron sparing treatment, that does include ablation. That one is, that's the number, so the denominator is the number of patients who undergo surgery, so either radical or nephron sparing or ablation. So that's the denominator. And then the numerator was just nephron sparing treatment, which we deemed to be nephron sparing surgery or ablation. So performance indicator 6 includes ablation, performance indicator 5 does not.
Thanks, Emily. And there's more information in the State of the Nation reports, which are on our website. Just one final one I think we'll have time for before we move on. It was just regarding the SACs and the 30-day mortality post systemic anti-cancer therapy administration. Did you review any of the specific toxicities that were causing those deaths?
No, we didn't. We just it was any patient that had a record of death within 30 days of starting systemic therapy. That is something that we could further go into in a future report, is to maybe picking out which toxicities we include and which ones we don't include. But for this one, for this first iteration, it was more of a broad stroke. Yeah.
Fantastic. Thank you very much, Emily. Please keep your questions coming. Emily can answer those offline or take them back to the team. And as I said, the formal reports are online, but thank you for a fabulous summary. And now very pleased to ask our next speaker to join us, which will be Suzi Nallamilli, who's the Clinical Fellow for the National Audit of Pancreatic Cancer. Suzi, it's all yours.
Thanks, Ajay. Good afternoon, everyone, and welcome to the Pancreatic Cancer Audit Summary. My name is Suzi, and I'm the Clinical Fellow within the NPaCA team, and I'm really excited to share our audit findings with you this afternoon on behalf of our wider team. Next slide. So as this is a healthcare audit, it's only right that we have a multidisciplinary team working within this audit. And these are some of the internal team members that helped us to produce our reports. Next slide. This is the first national audit across England and Wales reviewing pancreatic cancer services. So before we dive into the results, I think it's really important that we understand the data that we're reviewing and what is the cohort that we've selected to audit. In England, we have the reporting period of 2020 to 2021, and in Wales, we have it for the 2022 calendar year. In terms of inclusion criteria, we've audited patients aged over 18 years old with new diagnosis of pancreatic cancer. We've used the ICD-10 codes to select our cohort, And as you'll see in the orange box, the C25 is the main pancreatic cancer code. And from this, we've excluded neuroendocrine tumours, as we know that they're managed very differently. However, we've also included the C24 codes, as we know that they follow a similar pathway. Some of the key demographic findings from our audit are, number one, that a median age of diagnosis was 74 years old. And number two, the majority of patients, so approximately 60% of patients, present with stage 4 metastatic cancer. Next slide. So the beauty of these audits is that it really tells you a patient's journey, and each one of these indicators their NPaCA has chosen will fit into part of this timeline. So when we think about how patients will be manoeuvring through the cancer service pathway, from presentation, diagnosis, receiving treatment, and managing survivorship, we can use the audit data to identify gaps in the service and to understand where the bottlenecks may be in this pathway. Next slide. So obviously we'd love to have hours to tell you all about the great findings, but actually for today, we've just had to include a few indicators with interesting findings to present, and these are the ones that are listed here. If we could just go back one slide, sorry. Thanks. So these are the indicators that form the basis of our 5 recommendations for clinical change. And I implore anyone who's interested or anyone who works within the HPP services to access the full report and to think about how these results could impact their own practice. Next slide. So NICE have published guidelines on the diagnosis and management of pancreatic cancer back in 2018. And within the workup to diagnosis section, they recommend that people with suspected pancreatic cancer should have their care agreed by a specialist pancreatic cancer MDT. So we had data on MDT discussions for England only, and our audit found that 76% of patients had a record of being discussed at an MDT. In some trusts, over 90% of patients were being discussed, and in others, less than 70% were. So you can see there is quite lots of variation in practice across the nation. This is an important finding which formed the basis of our first recommendation. For everyone diagnosed with pancreatic cancer, including those with non-resectable disease, we would recommend an MDT discussion. Of course, many of us understand the pressures of long lists of patients to discuss at specialist MDTs. However, it is important that all patients are discussed, at least at the local MDT level, to ensure that relevant team members, such as dietitians and palliative care staff, are giving their specialist input on the patient's care. Next slide. The HPV diagnostic pathway can be long and complex. Pathology can be difficult to obtain due to the anatomy of that region, and repeat investigations are often required, leading to more delays in the pathway. The overall NHS target for diagnosing cancer is 28 days from referral. However, because pancreatic cancer grows so rapidly, a faster 21-day target has also been recommended. We've analysed data on urgent GP referrals in England, and as you can see in the blue box, 51% of people were diagnosed within 21 days of referral, and 68% were diagnosed within 28 days of referral. If you look at the orange box, the national target from time of referral to time of starting treatment is 62 days. And when we're talking about treatment, we're talking about disease-modifying treatment such as surgery, chemotherapy, or radiotherapy. And our audit found that for England, only 1/3 of the patients were receiving treatment within this target. Next slide. When we look at Wales in 2022, in the blue box, we can see 70% of patients were diagnosed within 28 days of referral. And again, looking at the orange box, 25%, so only 1/4, were treated within the 62-day timeframe. And when we had a closer look into median time for the time from referral to starting treatment, it was almost 3 months, which is why only 1/4 were treated within 62 days. So with all this information in mind, it brings us to recommendation number 2, a need for trusts to review their diagnostic pathways. And we encourage trusts to review the HPB faster diagnostic guidance, which sets out the recommended sequencing of events for this diagnostic process, and also helpfully identifies time points by which patients should be reaching this pathway. Next slide. So now we've discussed the diagnostic process, let's focus on treatment. So in this audit, we've analysed patients as two groups, those with non-metastatic, stage 1, 2 or 3 cancer, and those with metastatic stage 4 cancer, as the treatment options given to both groups are quite different. And within these groups, we've had a closer look into what types of treatment each group are receiving, which are listed below. If we consider the non-metastatic group, in England, 55% of pancreatic cancer patients had received some form of disease-targeted treatment, and for Wales, this was 41%. Moving across to the metastatic group, in England, 25% of patients received some form of disease-targeted treatment, and 16% in Wales. So we can really see that the rates of treatment were linked to the stage of disease that the patient has. Next slide, please. The rates of treatment were also strongly related to performance status across all stages in both England and Wales. So if we look at this graph, for example, and focus on the stage 1 disease, we can see that amongst those patients who are fully active, which was the performance status 0, the purple bar, almost 80% of patients are getting treatment. In that same stage 1, if you compare it to patients who have poorer performance status, so performance status 3 or 4 in the orange bar, less than 5% of patients were getting treatment. Next slide, please. So this forms the basis of our third recommendation. If the diagnostic pathway is very long, patients may decondition due to the burden of their disease. And ultimately, this leads to fewer patients being treated by the time they've come out of this pathway. So all trusts need to be actively supporting patients to optimize their nutrition, their fitness, to keep them well enough to receive treatment. And we believe that with this early support, we'll help a greater number of patients receive important cancer treatment. Next slide, please. The final two recommendations are regarding support for our patients, and we have data on these metrics for England only. The NHS have cancer clinical nurse specialists, CNSs, who support people during their cancer care. 86% of patients in England were reported to have been seen by a CNS. Data on CNS involvement was missing, though, for half of our patients. So it's probably a good opportunity here to mention that in order to accurately understand the services in England, we do need trusts to improve on capturing data for certain metrics. So our fourth recommendation is to review the provision of clinical nurse specialists, especially if the organisation has noticed that not all new cancer patients are able to see or contact a CNS. And ideally, we want this contact to be early on in their cancer care. Next slide, please. So when the pancreas has a tumour, it may not produce enough enzymes to break down the food that we eat. So pancreatic enzyme replacement therapy, or PERT, is a form of medication that contains these digestive enzymes and it helps to break down the food. In England, half of the patients with pancreatic cancer were prescribed PERT. When you take a deeper look, you can see that actually a much higher proportion of these patients who had surgery had a higher proportion of PERT prescriptions. And it's important to highlight that now there is actually a national shortage of PERT. We believe this will be an ongoing issue for at least another year. However, pancreatic patients are a key cohort that we should be prioritising for this treatment. So our final recommendation is that patients should be assessed for whether or not they would benefit from PERT and should then be offered this as per the NICE guidelines. Next slide. The audit has analysed survival data on pancreatic cancer patients from the time of diagnosis. The overall survival figures are presented here. And in England, at 1 year, 26% of patients survived from the time of diagnosis, and 13% survived at least 2 years. In Wales, similarly, 25% survived to 1 year from diagnosis. So these results really highlight why it's important to act quickly for our pancreatic cancer patients. Next slide. So we've discussed some of the important findings from our annual report, and some are particularly sobering. But the question is, well, what's next? So trusts should review their own metrics that we have published alongside this report and compare their performance to national values and also to other trusts in the country, and really consider how to improve their local practice. To help with this, the audits have also published quarterly reports on some of these metrics, and these use more recent data so you can keep a track on how you're doing as a trust. We really encourage trusts to look at these dashboards and please feed back to us on their data. Next slide. So appreciate there's been a lot of information condensed into a short space of time. So here are a few take-home messages from the report. Number one, 60% of patients are metastatic at the time of diagnosis. And we've already discussed that the higher the stage of presentation, the fewer the number of people receiving disease-modifying treatments. Number two, the HPV diagnostic pathway needs to be more streamlined and more efficient to prevent patients deconditioning and to help more patients get disease-modifying treatments. And finally, number three, survival is poor, so we do need to review the support of our patients during this important time for them. Last slide. Thank you very much for listening to this talk, and I'd be happy to answer any questions.
Thank you very much, Suzi. That was extremely clear, but as you said, sobering, many of these results. Can we stop the share, please? We do have a few questions. So we've got one question. I hope I've interpreted this correctly. So one of the questions was around how patients got onto the diagnostic pathway. I think you referred to 2-week wait referrals, and so you have the 62-day targets. Were there any other routes to diagnosis that you were looking at, particularly sort of outpatient referrals, routine emergencies that you can comment on?
Yep. So for England, we had a discrepancy. We had it broken down into types of referral route. So we had the urgent 2-week wait GP route. We also had an other route that we have listed in our report. And this other route is a bit of a catch-all of all the other referrals. So we imagine these are predominantly A&E referrals. So patients presented as an emergency, being seen, and the A&E team have referred on. Or it could be other consultants seeing in other outpatient clinics who have then put them on a fast-track cancer pathway. The problem is that this other group aren't, fully complete, and we don't have clear information on where they come from. So it is easier to talk about the GP route. This will be something to look into for future audits. And for Wales, we just had a catch-all referral date, and we didn't have any specific information on where the referrals came from for the Welsh patients.
I think that's important to highlight. It's the sort of first year of presenting the results, and the data quality and more time spent in terms of getting that additional granularity would allow a wider spectrum of information around that diagnostic pathway. There's a question around prehab, actually, and whether there's any way of monitoring prehab, because we know that's extremely important, as you referred to, in terms of fitness.
I agree. I think prehab will be so key for all our patients, especially to prevent that deconditioning that we mentioned. I think it's difficult to actually monitor who's getting prehab, but I think, again, if all trusts do a local audit, look at their services and look at those patients who have performance statuses that say, well, you're eligible, your performance status 0, 1 or 2, well, why is it that they're still not getting the treatments? Or maybe even the patients who have performance status 3, can we get them to have prehab? Can we get them to a performance status 2 and keep them fit enough to get this treatment? So I think it's really a chance for all the trusts to look at what their own processes are and see if they can add a prehab service. I know that in previous hospitals, we had great kind of oncogeries and prehab services where they have actually gotten early input from medical staff. They've optimized their medical comorbidities, and all of that really helps to get the patients fit enough for treatment.
And what measures are we using for understanding prehab? Is there anything that we can look at within these data sets specifically?
That's a great question, actually. That might be one that I have to come back to the team and to the person who's asked on. But I think, yeah, there's nothing specific that comes to mind at the moment, I'm afraid.
Yeah, I think just to add further depth, a lot depends on whether there's coding for particular prehab services and what constitutes it. So I think that also highlights there's an ongoing methodological work that we do within the audits to be able to capture things like prehab. We've done it across the other more established audits, but it does take some time. But that's actually an extremely good point, which we will take back to the team. Another question came to around the timeline. So you talked about the GP referral, the 2-week wait, the 62-day target. But naturally, someone's asked the question, well, diagnosis date and decision to treat date are different. How did you handle that within your analysis?
So there is a variable within the data sets that we use that are called diagnosis date best And this is the date of diagnosis that we're given. So we're able to actually use that date as the starting point for our diagnosis and the workup. For the treatment dates, we've then said, well, who's having these active disease-modifying treatments? So who's had a surgery, who's had chemotherapy or radiotherapy, and that's then chosen as the date of the first cycle or the first fraction of radiotherapy. That's the date of their treatment starting. And then from there, we can work out that pathway, date of diagnosis that we're given and date of treatment that we've worked out, and then seen the pathway lengths.
You've set off a cascade of very good questions, so I'm going to keep going. We have time.
Yeah.
So there was a question around a national push towards, do we need to discuss every patient? As you said, people have quite long MDTs, especially with the specialist MDTs. Do you think that's affected the discussions around metastatic patients with pancreatic cancer, particularly those with poor performance status?
Yeah, and I think there's probably no right answer, and I know that every hospital will have quite different pathways. I think it's more, as you talk to different healthcare professionals, you realise the input that each specialist can add, the therapy staff, the dietitians, the palliative care team, the CNSs. And if a patient, even if they're metastatic and they're not going to have surgery, there is such a benefit to be gained from them still being discussed at an MDT. And I agree they don't need to be discussed in the once a week, very specialist pancreatic surgical MDTs with the surgeons involved. But it is important that they're still discussed at a local setting. I think they can have so much benefit from just being plugged into those right services. And again, it kind of all links to what we were saying about prehab and keeping them fit enough. There's always a hope that if they're plugged into the right service early enough with the right symptomatic and supportive care, maybe they'll actually be able to have a high proportion of patients getting active treatments. But it is tricky. MDTs are once a week and they're long lists.
Thank you. There was questions that keep coming up around prehab. I might answer them, one of them for you, because
yes,
they're
please.
asking around definitions and how we can pick them in the data sets. I think that is a piece of work that needs to be done to actually get the different definitions as such, and people have talked about psychological, physical perspectives on that, including stopping smoking. So I think that is an area that the pancreatic cancer audit would be looking at. There was one question around, are you seeking to identify whether patients are referred for palliative care and the timing of that?
Yeah, we know that definitely, as we were saying, we're obviously mentioning 60%-ish of patients are metastatic, and they will be obviously needing a lot of palliative care input. We haven't described, that's why we haven't had a chance to say that these are disease-modifying treatments, but we absolutely know how important palliative care treatments are for these patients. We haven't at the moment got a way of identifying exactly who's been seen by palliative care. Again, that might be something we'll look into doing for future audits, because we know from discussing with our CRG, our clinical reference groups, how important that palliative care and that supportive input is. So it'd be great if we could have a way of seeing exactly who's been seen, as, again, if that's such a massive part of our cohort, it's an important next step to look at. So it would definitely be something to look at for future audit work.
Thank you, Suzi. There's some general questions around implementation of the findings and data quality, which we will get back to people offline. We cannot respond to those questions. I think given time, we will now move on, but thank you very much for your presentation.
Thanks, everyone.
So up next, we have the report of the National Non-Hodgkin Lymphoma Audit, and Ruhi Kanani will be taking us through that. Thanks very much, Ruhi.
Thank you, Ajay. So I am going to be presenting on behalf of the National Non-Hodgkin Lymphoma Audit. And as previously mentioned, I'll be talking through the State of the Nation report, which was reported about a month ago. And we'll be talking through both the key findings and the recommendations. Next slide, please. So as already mentioned, this is one of 10 national cancer audits, and within our team there are multiple disciplinaries involved. So we have Kathy Burton, who is our clinical lead for haematology, David Cutter, who is our clinical lead for oncology. We've got our two methodologists, Kate Walker, Luhan, our data scientist, Ella Barber, and also Vicky Hart, who is our project manager, and myself as the clinical fellow. Next slide, please. So the aims of the audit, as we've already mentioned in the previous presentations, it's to support NHS organisations both in England and Wales to benchmark their care of people diagnosed with non-Hodgkin lymphoma against measurable standards. And the aim of this is to also help identify any unwarranted variation in care delivered, and also to help provide feedback to local trusts, hospitals, health boards, to provide information on the delivery of care, the quality of care that patients are receiving, and also ensuring that we're giving tools for local improvement initiatives to help improve the care that's delivered. Next slide, please. So this led to our quality improvement plan, which was published as well last month, and it identifies 5 really key healthcare improvement goals, and that relates from beginning of diagnosis to the treatment delivered until outcomes. So to list them, number 1 was improving timely diagnosis and treatment. Number 2 was ensuring that patients and people with NHL are receiving treatment appropriate to the subtype, ensuring that treatment is delivered safely and also reducing toxicity of treatment delivered, and improving overall survival. As well as all of those, it's also important to make sure that we're reducing variation in management across NHS providers, so everyone with NHL is receiving good quality care across England and Wales. These 5 key healthcare improvement goals led to 11 performance indicators, which were had come up with following discussions with our clinical reference groups, our patient bodies, our charity bodies as well, and also from literature review on what's important to people with NHL. Next slide, please. So that led to further analysis of the 11 performance indicators, and that led to our first annual State of the Nation report, which is what I'll be discussing in more depth today. And from those performance indicators that I'll discuss shortly, there are 5 key recommendations, which I'll expand on later. It's really important for me to highlight the data and reporting period for the results that I'm going to be talking through today. So for England, we reported across a 2-year period from January 2020 to December 2021. And for Wales, we reported for a year period from the year of January 2022 to the end of the year, December 2022. And you can see that we use slightly different data sources to gather our data for that. Next slide, please. So this is a long list of our 11 performance indicators, and I just wanted to highlight that there are 6 particular performance indicators that we'll be discussing in more detail. So these are the ones that have come up in bold. So they are listed and they cover all aspects from care from diagnosis to treatment to outcomes. So the first one is about the proportion of people diagnosed with non-Hodgkin lymphoma who are seen by a clinical nurse specialist. The second one I'll be talking through will be the proportion of people diagnosed with non-Hodgkin lymphoma who were discussed at a lymphoma or hematology multidisciplinary meeting within 4 weeks of diagnosis. The next one's about proportion of people with high-grade lymphoma who start chemotherapy within 62 days of referral. Next, it will be about the proportion of people with high-grade lymphoma who start radiotherapy within 8 weeks of end of first-line chemotherapy. And this one is particularly about timing of radiotherapy delivery rather than the number of people who receive radiotherapy. The next performance indicator is about the proportion of people receiving radiotherapy reported by the many various subtypes within NHL, and then looking at overall survival for these people with NHL, particularly high-grade lymphoma. The other performance indicators are undergoing further development work and will be reported in future State of the Nation reports. Next slide, please. So for the first audit, it's really important, and first report, it's really important to highlight data quality is a concern and issue of ours. So we have reported on data completeness for a number of different demographics, age, sex, ethnicity, deprivation, and we can see relatively good completeness for many of these for England and some of these for Wales. But I particularly wanted to highlight the staging being a concern. As you can see, around 70% had complete staging for Ann Arbor staging system in England, but only 30% in Wales. And for the Benet staging, again, about 30% in England and 10% in Wales. And this is an area that we'll be talking on and a focus of one of our main recommendations from this. The other thing I wanted to highlight is clinical nurse specialist record within the data and MDT discussion record in the data, as they form part of 2 of our other key performance indicators. And we can see again, data completeness is an issue, and no data was available for MDT records for Wales. So these are areas that will need to be improved upon through our report and our recommendations to help provide more accurate information going forward. Next slide, please. So to give you an idea of the descriptives of the people included within the audit, and also about one of our performance indicators pertaining to clinical nurse specialists, I'll talk through the results listed below. So we can see that diagnoses per year, about 14 to 15,000 people within England were diagnosed each year, and around 600 in Wales in 2022. The mean age across all the cohorts was 69 years, and the distribution of high-grade and low-grade cases was pretty even, around 50%, both in England and Wales for each of the years. We can also see for clinical nurse specialist involvement, as I already mentioned, data completeness was an issue, but where there was a record, around 80% was seen within the England cohort and around 96% in the Wales cohort. This number did increase if they were high-grade cases, and there's more information about that within the actual body of our State of the Nation report, so I'd implore you to read that if you can. Then it comes on to staging, so we can see around 70% of cases presented with an Ann Arbor stage of 3 or 4, and 60 to 80% of cases presented with a Binet stage of A, so earlier stage, and this may be due to the slower nature and slow progressive nature of CLL for the Binet staging, and that may explain why there is a sort of converse in the results there. Next slide, please. So one of the main performance indicators that I've talked about is the proportion of people with NHL who were discussed at a lymphoma or hematology MDT within 4 weeks of diagnosis. So we can see around 65 to 70% of patients in England in 2020-2021 were discussed within 4 weeks. And you can see with the results next to that, that the proportion of that are more likely to be discussed if you are a high-grade case compared to if you're a low-grade case. Missing data is an issue, so we've reported based on the data available, and unfortunately no data was available for Wales, so we've only reported for England here. There is a wide variation between providers, and that is something that's really important to highlight to trust to ensure that there are local initiatives to look into this as a way to improve this in the future. Next slide, please. The next performance indicator pertains to proportion of people with high-grade lymphoma that encompasses Burkitt's lymphoma, diffuse large B-cell lymphoma, or high-grade T-cell lymphoma, who start chemotherapy within 62 days of referral. So we can see, again, overall, less than 2/3 of patients within England and around half in Wales start chemotherapy within 62 days. And again, having a look at the breakdown amongst trusts and providers and health boards, there is a wide variation across England and Wales. Next slide, please. The next performance indicator is about proportion of people with high-grade lymphoma who start radiotherapy within 8 weeks of end of first-line chemotherapy. And I just wanted to highlight again, we're looking here about the timing of radiotherapy. So we looked at patients who received anyone who received radiotherapy within 6 months after first-line chemotherapy, and how many of those received it within the first week, because we know more timely radiotherapy yields better outcomes. We didn't have any data on regimen-level chemotherapy, so the timing and stop of chemotherapy for Wales. So unfortunately, we're unable to report on this performance indicator for Wales. But from the English data we do have, around 40% of cases started radiotherapy within the 8 weeks. And again, there was a wide variation across providers in England, and that would need further exploration as well. Next slide, please. The next indicator is about the proportion of people with NHL who receive radiotherapy reported by subtypes. Now, NHL has multiple different subtypes, and we've reported on radiotherapy delivery for each subtype within the State of Our Nation report, which is a very interesting read, and I'd recommend anyone to go and read that if they can, to understand the delivery and how it varies across different subtypes. But to give you an overall view of what the data shows, we can see around 13 to 14% of people with NHL receive radiotherapy within 1 year of diagnosis, and the number is slightly lower at 6% in Wales. The 3 most common subtypes that receive radiotherapy within the year are diffuse large B-cell lymphoma, cutaneous T-cell lymphoma, and marginal zone lymphoma. There was some concern about the capture of radiotherapy data in Wales, and that may explain why the percentage there is a little bit lower than we can see in England. Again, when we looked at by different subtypes, we could also see a variation in use of radiotherapy between providers for all the subtypes mentioned. So again, I would implore you to read that if you can to have a better understanding of that data. Next slide, please. The last performance indicator I'll be talking you through today is survival. So you may remember at the beginning I talked about overall 2-year survival is what we were hoping to present. However, because we were presenting and gathering data from 2020 to 2022 for England and Wales respectively, we didn't have sufficient follow-up time to report for 2-year survival, and therefore for the purpose of this we've reported 1-year survival. But in future State of the Nation reports we hope to be able to report 2-year survival as well. Again, in our State of the Nation report, we have reported survival by subtypes for all the high grades and also the low grades as well. So it's a very interesting area to read if that's something you would like to look at. But for purposes of this, I've just summarised that the overall 1-year survival is around 80%. This reduces to 70% for high grade cases and increases to 90% for low grade cases. Next slide, please. So I'm aware I've presented a lot of data to you today in a very short period of time, so I wanted to highlight 3 key themes that we've gathered from this itself. One pertains to missing data. So we know that record keeping contributes to that, and also the IT infrastructure also contributes to that. And that's an area that will need improvement so we can provide more information about delivery of care. The second one is about delays. So we can see there are delays in MDT discussion, and also delays in starting treatment, whether that be chemotherapy or radiotherapy following first-line chemotherapy. The last key theme is about radiotherapy. So there is a wide variation in care and delivery for different subtypes, and understanding the use of radiotherapy and changing patterns in care and delivery of radiotherapy is really important for us. I'm aware we've also only presented data on 6 of the performance indicators, and there is 5 other performance indicators, and so therefore further development work will be needed on these, and that is the focus of our group going forward, and hopefully we'll be able to provide more information on that in the coming reports. It's really also very important to highlight that the data was collected between 2020 and 2021 for England and also 2020 for Wales. So inevitably the data will be impacted somewhat by the COVID-19 pandemic. And so some of these results may be atypical to some degree. Next slide, please. So this led on to our 5 recommendations. The first 3 are clinical and the last 2 about data quality. So I'll read through them now with you. So the first one is, and first 1 to 3 are regarding recommendations to cancer alliances in England, working with trusts and also health boards in Wales. And they are looking at identifying and addressing factors delaying people with NHL being discussed at a haematology or lymphoma MDT. And that's looking at the referral pathways leading up to that point, the facilities and ability to access staging investigations, and also the record keeping within the MDT itself. The second recommendation is about identifying pathway factors contributing to delays in people with high-grade NHL starting chemotherapy within 62 days referral, and developing other strategies to help local improvement initiatives and also general improvement in reducing delays for these people with NHL. The third one is about identifying patient and hospital factors contributing to delays in radiotherapy since last administered dose of chemotherapy. So ensuring that patients who are and should be getting radiotherapy are getting it in a timely manner after first-line chemotherapy. Next slide, please. The last 2 are to do with data quality, and it's a theme I've mentioned throughout the results today. The first one, which is particularly important, is ensuring that there's an adequate resource allocation to improve quality and completeness of data, particularly staging and prognostic indices. We know there is a large amount of data missing for both of these, and only sort of 9 to 11% of cases had a recorded prognostic indices for NHL. So if we're able to improve that, we can then ensure that patients are receiving the appropriate care and also help guide our service evaluation and also improvement initiatives in the future. The last one is about ensuring that there is more comprehensive cancer data in Wales. So this is targeted particularly at health boards in Wales, ensuring that there's enough information and record keeping for chemotherapy and radiotherapy delivery. And I'm fully aware that this is already in the process of being developed as part of the newly established digital strategy for Wales. So there are efforts to improve this, and hopefully in the coming audits and reports that we report on, this will be demonstrated there. Next slide, please. So As the other teams have already mentioned, we greatly appreciate any feedback, any queries about the audit itself. You can access our full report on our website, and also our quarterly reports, which also feedback to individual trusts about data quality. And please email us if there's any questions, and we can also add you to our newsletters to give you updates on the work we're doing, and also follow us on our social media platforms. Thank you very much for listening, and open the floor to any questions.
Fabulous. Thank you, Ruhi. Quite a lot of data, and NHL being extremely complex with the subtypes. So we've got a few questions. We've got 5 minutes for them before our break. So one of the initial questions was around low grades or CLLs. Do you think they're even considered sort of worthy of MDT to some degree, because a lot of them are monitored, and so cancer services are not even informed of them? Do you think there's a sort of cultural factor to this, or what's your thoughts?
So there definitely is, and as mentioned previously, we're fully aware of the clinical pressures and MDT limitations with time, space, and staffing. I think it's still important to have a record of a discussion, but I understand it's easily said than done. We have had these conversations within our clinical reference group, and we still felt it was important to be able to report back on this for all the subtypes so we have an understanding. But I fully understand it's easier said than done within the limits of the NHS at the moment and resources, but I still think it'd be valuable for patients and also staff to have a record of an MTD discussion for each patient.
Thank you. A couple of questions around sort of 62-day time frame from referral to treatment. I think the first one really is, I mean, is 62 days a bit too generous for high-grade lymphoma? Should they be having it sooner? What's your initial thoughts on that?
Yeah, so that's something we noticed both from anecdotal experience and also from our clinical reference group, is that a lot of patients start their treatment very quickly because often they can present as an emergency presentation or with very aggressive disease, and that's why they bypass the MDT discussion and treatment starts even before they get recorded. So the 62-day is a target, and obviously we would, even though the patients are probably starting treatment a lot sooner than that, and 62-day may be a bit long, we're still seeing that within that, the high-grade cases there's not 100% of the group and cohort being started treatment that quickly anyway. So I still think it's a valuable cutoff to have, but fully aware that clinically it may be more relevant to have a shorter timeline, and that's something I'll take back to the team and see if we can do some further analysis to try and understand that distribution and time delivery a bit more.
Certainly be very interesting, I think. And just in terms of those receiving systemic therapy, which we know is extremely effective, versus those who don't, was there any understanding of the determinants of that? Any factors that might be associated with those receiving treatment? Because, as you said, there's quite a lot of hospital variation for that indicator.
So I think that to answer that is sort of a twofold approach. So first of all, we know the completeness of the data isn't as good as we would like it to be, and we hope with further reiterations and feedback to hospitals that will improve and we'll have a better understanding. So it's hard to make any definitive conclusions based on what we have. And also part of understanding and developing our other performance indicators, understanding the different regimes and also the determinants of who receives care or not. So that is a focus of our future development work within this audit. And hopefully we'll be able to provide more information about that in the coming months to year.
And that will certainly inform a lot of the quality improvement activity of the particular groups that are affected. And you mentioned around survival, and you said 2-year survival wasn't possible, but you were able to look at 1-year survival, for instance, and that's 70% for high grade. How does that compare to sort of international standards, either with audit data or even published international standards? Is it much less or similar?
So I think there are flaws in sort of presenting it overall because of the different subtypes and how each of the different high-grade subtypes behave, even within themselves, and the huge heterogeneity across it. So I think looking at and having had reviewed these results for each subtype, which is in a table listed in our State of the Nation report, they didn't seem to be too far off what we would expect. But again, the completeness is an issue, and I think it's more valuable to look at them by subtype rather than as an overall, if that makes sense.
Yeah, certainly. I think there's been a very good point around knowing if there's any delays and even that 62-day target and the impact on survival as well. So I think you have receipt of care, timing of care, implications on survival overall. But as you said, having a better understanding of what those subgroups are within that would make a difference. So there's a point being made around a 4-week limit, having this 4-week limit for MDT discussion. Do you think that's reasonable? I mean, there's a lot of molecular markers and various analyses that need to go on, particularly for watch and wait patients. So what are your thoughts on that?
So I think it's a difficult one. I think the 4-week mark was sort of came up with within our CRG meeting. We did actually look at the number of people who were discussed within 8 weeks as well to see if this was a record keeping issue or a timing issue. And we did see that a high proportion, around sort of the high 80s to 90%, were discussed within 8 weeks. So they were being discussed. It was due to the timing. And we're also aware that the pathway to MDT can be quite convoluted for non-Hodgkin lymphoma. It's not a standard pathway. They are going through multiple other specialty pathways. So we acknowledge that it's going to be hard to meet that 4-week target. And that's why we have been looking at other time points as well to try and have a better understanding of that, especially if they're going through other MDTs like ENT or breast or any other ways that they could be diagnosed. And we also are aware that a lot of specialist tests like bone marrow biopsies and PET scans are, the resources are limited, and we know that can contribute to delay. So we are trying to explore that a bit more and trying to look at other time points beyond the 4 weeks to have a better understanding of that, and also try and find ways to advise other hospitals to have local initiative improvements as well to look into that.
Thanks, Ruhi. And these questions have been fantastic because it is an iteration. This is not the only performance indicator that'll be used or the only version. So we do value this feedback to make the work more actionable. So we're bang on time for our first break. Thanks very much, Ruhi. Verity, if you could put our slide up. Essentially, we've got a 15-minute break. We'll be back at 3:20. People could come maybe a minute or two earlier. We would be delighted for your attendance. We've got reports from the ovarian cancer audit and also 2 of our breast cancer audits. That's primary and metastatic breast cancer. Thank you for your attention, and we'll see you very shortly. We're at 3:20. Welcome back, everyone. We had 3 fantastic talks outlining the findings from the kidney, non-Hodgkin's lymphoma and pancreatic cancer audit. As I said, the reports are available on the NATCAN website. We will also be publishing the slides, and also the webinar will be available on YouTube, and we'll send a link towards that. I'm now delighted to present Georgia Zachou, who's going to be presenting around the results of the ovarian cancer audit. Georgia, the floor's yours.
Great. Thank you very much, Ajay. Good afternoon, everybody. I hope you all feel refreshed after the break. And my name is Georgia Zachou, and I'm the clinical fellow for the National Ovarian Cancer Audit. Thank you very much, Julie, Verity, and Sigita for organizing this amazing event. Next slide, please. So I'm presenting the results on behalf of the National Ovarian Cancer Audit team, and I'm not working on my own. We are a multidisciplinary team consisting of our clinical leads, Professor Sudha Sundar, who's our surgical clinical lead, and Professor Agnieszka Michael, who is our medical oncology lead. And we have Joe, who is our senior project manager, and 3 esteemed methodologists from the London School of Hygiene and Tropical Medicine, Professor Jan van der Moller, Dr. Ipek Gururkansi, and Mr. Andrew Hutchings. Next slide, please. And the National Ovarian Cancer Audit is a new audit. However, we are drawing on the work that's already been done by the Ovarian Cancer Audit Feasibility Pilot, which was a project started in 2019 and also used routinely collected data and has published 5 reports to date. There were some key findings from the feasibility pilot that helped us a lot. So they saw that there was great variation across cancer alliances on stage of diagnosis, treatment rates, and survival outcomes, both for 1 and 5 year survival. And we learned some important lessons. So we saw that there were issues with data completeness, especially for key data items such as FIGO stage, performance status, and recording of residual disease. We also kind of realized that reporting at the Cancer Alliance level was not actually helpful for the ovarian cancer clinical community. And the reason for that is the particular organization of ovarian cancer care in a hubs and spokes model. And reporting at the Cancer Alliance level created issues with some cancer alliances. For example, West Midlands Cancer Alliance having 5 separate cancer centres. Next slide, please. So going forward from the ovarian cancer audit feasibility pilot, we developed 5 healthcare improvement goals. The first one is to increase the proportion of patients receiving timely diagnosis and treatment decisions. The second one is to increase the proportion of patients receiving molecular diagnostics. The third one is to increase the proportion of patients receiving surgery. The fourth one is to increase the proportion of patients receiving chemotherapy. And last but not least, to improve rates of survival and reduce variation in survival. Next slide, please. And in terms of the data that we use for the 2024 State of the Nation report, for England, we included women diagnosed with ovarian cancer in 2021. And for Wales, we included patients diagnosed with ovarian cancer in 2022. We reported 4 performance indicators. The proportion of emergency admissions 28 days prior to diagnosis, the receipt of any treatment within 9 months from diagnosis, which can be surgery and/or chemotherapy, the receipt of platinum-based chemotherapy within 3 months from diagnosis, and this performance indicator was only available for England, and 1-year survival. And we spent quite a lot of time understanding the organization of ovarian cancer care and creating these integrated gynecological cancer systems, which are cancer centers with gynec cancer units. And we found 40 cancer systems, gynecological cancer systems in England and 3 systems in Wales. For the emergency admissions indicator, we also presented results at the trust level. Next slide, please. And in terms of the demographics, we found 5,735 diagnoses of ovarian cancer in England in 2021 and 293 diagnoses of ovarian cancer in Wales in 2022. In terms of states, for both England and Wales, we saw that approximately 3 out of 4 patients are diagnosed with stage 2 to 4 ovarian cancer, and the mean age of diagnosis was 66.6 years in England in 2021 and 65.8 years in Wales in 2022. Next slide, please. And moving on to our recommendations. So the first recommendation is to reduce the current rate of emergency admissions by improving efforts to increase symptom awareness amongst women and primary care professionals, and by reviewing the diagnostic pathways to improve timely testing. And that recommendation was based on our first performance indicator, which showed that approximately 4 in 10 women had an emergency admission recorded 28 days prior to the diagnosis. Of course, the emergency admissions rate varied across the cancer systems in England and Wales. Next slide, please. And moving on to our second recommendation, which is to review the percentage of women with stage 2 to 4 or unstaged ovarian cancer who receive treatment of any type, which can be surgery or chemotherapy, explore and address some of the reasons behind the variation across the integrated gynecological cancer systems. And that recommendation is based on our second performance indicator on receipt of any treatment. And what we actually found was that 3 in 4 women received surgery and or chemotherapy 1 month prior and up to 9 months following the diagnosis. Again, there was a significant variation across the cancer systems in England and Wales, and the average results that we found were similar to the findings from the feasibility pilot in 2019. Next slide, please. And our third recommendation was around chemotherapy only, and is to review the use of platinum-based chemotherapy in women with epithelial ovarian cancer, stage 2 to 4 or unstaged, and explore and address some of the reasons behind the variation across the integrated gynecological cancer systems. And the basis of our third recommendation is our performance indicator number 3, which showed that 2 in 3 women received platinum-based chemotherapy 1 month prior and up to 3 months from diagnosis. We did not have data on chemotherapy regimes for Wales, but that's something that we would like to report on in our future State of the Nation reports. And again, we saw significant variation across the cancer systems in England. Next slide, please. And moving on to our fourth recommendation, which is around survival. We encourage people to review 1-year survival in women diagnosed with ovarian cancer, explore and address some of the reasons behind the variation across the integrated gynecological cancer systems. So in terms of the unadjusted 1-year survival, in England, approximately 7 in 10 women survived at least 1 year after diagnosis. And the survival varied across the cancer systems in England from 54% to 86%. Next slide, please. And the Wales results was similar. We saw that 3 in 4 women survived at least 1 year after the diagnosis, and the variation across the cancer systems in Wales was between 72 and 76%. Next slide, please. And after looking at the unadjusted results, we realized that it will be really important for the clinical community and the people that are looking at our results to see if there's any reasons behind this variation. So we went on and we did some adjusted analysis for the results. So we adjusted for different items, which are age, ethnicity, deprivation, stage, morphology, grade, Charles comorbidity index, and frailty score in order to account for differences in case mix. And on the right side of the screen, you can see the funnel plot with the adjusted 1-year survival by the different cancer systems in England in 2021. And the straight line, around 70%, is the national average, and each dot represents a cancer system in England. And the dashed lines are actually the different limits, so the 95% and the 99.8% limit. Of course, we did have some missing data, which were imputed using multiple imputations. Next slide, please. And our last recommendation is regarding data completeness, and is to improve the completeness and quality of data items recorded in the national cancer data sets. For example, the percentage of women with recorded diagnosis based on histology or cytology in the national cancer registration data, and the percentage of women with recorded staging information. And this recommendation comes from our data completeness percentages, where we saw that 12% of women with ovarian cancer in England in 2021 and 11% of women in Wales in 2022 did not have histology or cytology recorded in the national cancer registration dataset. For states, we saw that 28.5% of women in England and 12.3% of women in Wales did not have any staging information recorded. So we think these two issues are really important for the future of our audit in order to be able to report on clinical performance indicators. Next slide, please. Yes, so these were the results from the National Ovarian Cancer Audit, and I'm very happy to take any questions, and thank you very much. And again, if you have any feedback or any questions about the audit, do not hesitate to get in touch with us. Thank you.
Thank you very much, Georgia. Can we just stop the share, please? Great. So there was a question around these gynae systems, as you referred to them, or hubs and spokes. So which of your, was it the survival results that were, because there's been a question about it. So the survival results are published at that gynae system level. And if so, where does the responsibility lie within that in terms of trying to investigate?
Thank you very much, Ajay. So we actually report all our performance indicators at an integrated gynecological cancer system. And these cancer systems have a clinical lead in their MDT. And we think that the responsibility lies within the whole cancer system. So the gynecological units, but also the gynecological center. So we encourage people to work as a team and try to investigate why this variation might be.
Okay, so there'll be that network that works together, and so we're encouraging and we provide further advice in terms of trying to review the results and particular reasons for that. And I mean, looking at that variation in survival that you mentioned, obviously you're able to adjust it for a number of factors which people are concerned about, not least comorbidity, age, etc. Were there any other major factors, even adjusting for that you could think of that could count for that variation? I mean, you looked at stage as well. Are there any initial thoughts or investigations ongoing within the ovarian cancer audit?
Yes, of course. Initially, we also wanted to adjust for BRCA status, which we know for ovarian cancer is an important factor that affects survival. But unfortunately, this year we did not have this data item, so we were not able to adjust for that. But we do hope in the next FIDs that we will be able to get the BRCA status and use that for the adjustment as well.
Okay, that's a point well made. I mean, we've got a couple of good questions. So one was around with the funnel plot, which looks to look, variation beyond the average or significant variation. Was there any outliers or any from that process, and what are next steps?
So because it's the first time that we present these results, we do see some systems that have potentially outlying results. But as I said, because it's the first time, we want to investigate it a little bit more and see if that's a data completeness issue or if these results might be for another reason. So we are liaising with these systems to make sure that the results are not due to a data completeness issue.
You mentioned that's across all the audits actually, when they've started, is that in the first year, obviously these are new indicators using different data sets. So if there is a cause for concern, we do raise this with a particular centre to investigate further, because data is one of them, but there was sufficient confidence in the results that they needed to be reported to investigate if there are any clinical issues. So they'll be looked at, and I think specific questions around number of cases, I think is when we sort of mature as an audit and have once we have confidence in those outcomes, that we can look at that association, but that is certainly something that is looked at. There's a question around ultra radical surgery for ovarian cancer. I don't treat ovarian cancer, but could you, and I know you do as a surgeon, but could you provide some thoughts around whether the availability of ultra-radical is variable across the country and whether that might be influencing the outcome you're observing?
So one of our projects is to be able to actually be able to look at the quality of surgery that's been provided to women with ovarian cancer. And in order to be able to do that, we need the residual disease. So how much disease was left behind. And this is what we call residual disease status. So if we are able to get this item, we will be able to look at the quality of surgery, which we know is associated with survival.
Thank you. And you mentioned around emergency presentation. I mean, it's something that comes up in other audits. Again, high rate. How do we have higher rates of emergency presentation for a number of different cancers? Is there any benchmarking that can be done with sort of England and Wales and internationally? I think it was 4, did he say 4 in 10? Is that similar to what's found elsewhere, or is that quite a big difference?
From international studies, we know that England is around 40%, but other countries are around 30-something%. So we know that this is something that potentially England and Wales can work on. And it's really important to look at the diagnostic pathway, because this is what we think is causing the high rates of emergency admissions, along with symptom awareness. So, we do encourage primary care professionals and women to get help if they have any symptoms that might be related to ovarian cancer.
Thanks, Georgia. I think it's about time for you. We could move on. Thank you very much for answering those questions.
Thank you.
Without further ado, we're pleased to welcome Sarah Blacker, the Clinical Fellow for NAoMe, which is the National Audit of Metastatic Breast Cancer. Thank you very much.
Thanks, Ajay. Hi, so as Ajay mentioned, my name is Sarah Blacker. I'm one of the clinical fellows working on the breast cancer audits, and I'll be presenting the findings of the first annual report for the National Audit of Metastatic Breast Cancer, or the NAoMe. Next slide, please. Firstly, I'd like to acknowledge the tremendous team effort that was required to produce the report from all of those present on this slide. Next slide, please. The National Audit of Metastatic Breast Cancer, as with the primary breast cancer audit, builds on work from the National Audit of Breast Cancer in older patients. It does have a broader scope than the NABCOP, including men and women of all ages. It has the ultimate aim of improving care and outcomes for those with metastatic breast cancer. So for this presentation, I'll start with an overview of our audit cohorts, and then I'll review some of the key results from this first annual report, including those that underpin its 4 recommendations. Next slide, please. As I go through the presentation, I'll be talking about results for 2 distinct groups within the audit. The de novo cohort describes those identified to have metastatic disease at the time of their initial breast cancer diagnosis, whereas the recurrent cohort describes those initially treated for primary breast cancer who then subsequently develop metastatic disease at a later stage. The audit methodology used a 12-month cutoff from the initial diagnosis to sort people into the de novo and the recurrent cohorts. Next slide, please. There are some challenges in auditing metastatic breast cancer, mostly with the recurrent cohort, whom are challenging to identify in national data sets. For example, where a date of recurrence is missing in the national data, these patients are then not flagged as having metastatic breast cancer in the national data available to us. We are aware of the limitations of our current methods to identify the recurrent cohort and are making active efforts that I'll describe later on to improve their capture year on year. Next slide, please. So this flow diagram illustrates the breakdown of the NAoMe cohort used in this annual report. So as you can see, in 2015 to 2021, over 300,000 people were identified as having breast cancer within national data. This annual report uses the most recent gold standard data that was available at the time of writing, and this is for the years 2019 to 2021, where there were 141,000 breast cancer patients identified. Next. Of these 141,000, 92% belong in the NAoPri cohort, so the primary breast cancer audit, as they were diagnosed with stages 0 to 3 breast cancer at the time of their initial diagnosis. And then just 8% of this 141,000 were diagnosed with metastatic or stage 4 disease at the time of their initial diagnosis, and this 8% forms the NAoMe de novo cohort. Next. If we then look at how the NAoMe recurrent cohort is formed, of those patients that started in the NAoPri cohort, unfortunately, some of them went on to develop metastases within the audit period, and that forms about 1%, and this is the small proportion of the NAoMe recurrent cohort. A larger proportion of the NAoMe recurrent cohort comes from those that were actually diagnosed with their primary breast cancer in 2015 to 2018, but then went on to develop metastases first diagnosed between 2019 to 2021. Next slide, please. You can see here from the patient characteristics used in our State of the Nation report that the recurrent cohort in this annual report is significantly smaller than the de novo cohort, when in reality we would expect this to be, we would expect the recurrent cohort to be the larger cohort. Next slide, please. I would therefore like to draw your attention to this guide on recording breast cancer recurrence produced by the NAoMe in collaboration with COSD. One of the 4 recommendations from this report is to ensure that the recording of the date and type of breast cancer occurrence in national data. This guide is intended to be used by breast MDTs to make pragmatic decisions on assigning a recurrence type and date. This guide is available on the NAoMe pages of the NatCan website. And if you take just one action away from this talk, I would urge you to utilise this guide within your breast units to improve the national data on breast cancer recurrence. Next slide, please. A second recommendation from this report focuses on data completeness. The graph shows variation between England and Wales and across key data items. Next. And the black line here signifies a target of 90%, which we can see is rarely met. I'd like to highlight the data quality for next, performance status, ER status, and HER2 status, as these underpin our ability as an audit to understand what treatments a person with metastatic breast cancer would be eligible for. We therefore ask that every breast MDT ensures they have a data lead responsible for ensuring data completeness and quality. Next slide, please. The indicator reported here is percentage of women with newly diagnosed de novo metastatic breast cancer discussed in a multidisciplinary team. This graph is taken from our data viewer that was published alongside the State of the Nation report and is accessible from the same webpage. So the graph shows organisation level data and allows the comparison of a particular NHS organisation to others nationally, as can be seen on the left, and those within the same cancer alliance, as can be seen on the right, with the selected unit shown by the black diamond highlighted here. Next. This example shows over 90% of patients are being discussed in an MDT. However, we can see that some trusts achieve this in under 10% of their patients, with significant variation nationally. What we would like to unpick as an audit is how much of this is due to data completeness and how much of this is a reflection of practice. We recommend that the care for all patients newly diagnosed with metastatic breast cancer should be discussed at an MDT. Next slide. Oh yeah, stay there, thanks. The indicator reported here is a percentage of people with recurrent metastatic breast cancer who had a metastatic lesion biopsied to inform care. Again, we can see that there is variation nationally, with the selected unit here, next, showing an average performance within their cancer alliance that is close to the national average. The NHS organisations for this indicator are more closely grouped than they were in the previous graph for MDT discussions, but we can see that generally the rate of biopsies used for recurrent metastatic breast cancer is generally pretty low. Next. We recommend that the biopsy rates are reviewed locally and increased where feasible if the results may have therapeutic implications. Next slide, please. The indicator reported here is the percentage of people with ER-positive de novo metastatic breast cancer who received CDK4/6 inhibitors as their first-line treatment in England. You can see here that there's significant variation both with age and with gender for the receipt of CDK4/6 inhibitors, and that there's a significant drop-off in the over 80s. This likely reflects increasing frailty in this age group, increasing comorbidities, and perhaps a drive to protect them from the side effect profile associated with the treatment. Next. We do not expect this treatment to be used globally, just that it is considered across all ages and genders. Next. So the indicator reported here is the percentage of people with HER2-positive de novo metastatic breast cancer who received anti-HER2 therapy as their first-line treatment. Again, we can see there's a disparity between the use of anti-HER2 therapy between women and men, and actually a larger difference here than there was with the CDK4/6 inhibitors. We also see a different profile on the graph, with a sort of a gradual decline in their use with age, with the lowest uptake being in that over 80s category again. Next. Again, we ask that this treatment is considered across all ages and genders and used where appropriate. Next slide. So to highlight, these are the 4 recommendations from our annual report. Firstly, we ask that every new case of metastatic breast cancer should be discussed at an MDT. Second, that units examine and increase their biopsy rates where feasible and where the results may impact treatments. We suggest that every MDT should have a data lead responsible for ensuring data completeness and quality. And we want to ensure the recording of date and type of breast cancer occurrence in national data. Next slide. So please do go on to access the full NAoMe State of the Nation report on the NAoMe pages of the NatCAN website. Next. You can then utilise our data viewer to see your organisation's data. Next. And our local action plan can be used for local quality improvement purposes. Next. And excitingly, later this month, we will be publishing our patient version of this first NAoMe State of the Nation report to improve the engagement with the patient and public. Next slide. Thank you for your time. Please do ask any questions you may have.
Wonderful, thank you, Sarah. Can we stop the share? Perfect. So a couple of questions have come up. Some we will answer offline because they relate to some of the data inputs within the databases. So one of the questions that has come up though is around the discussion of patients with recurrent or de novo metastatic disease, particularly recurrent. Is the expectation then that that's now a new sort of indicator of quality, the proportion of patients that do get discussed in metastatic SMDTs or primary breast cancer SMDTs? What are the thoughts regarding that?
Absolutely. We produced this performance indicator after sort of just reading sort of the international literature, as well as discussion with our key stakeholders within our audit advisory committee, our stakeholder group. And it was felt that, yes, although as other audits have mentioned, it is it is an ask for MDTs to discuss all patients. Actually, for patients to be discussed just the once at the time of their first diagnosis is important. Some patients will require further discussions, but the once as our target for the moment, and that this is important for both the de novo and the recurrent groups.
So there are some questions around the use of, and I will come to them. We have plenty of time for questions, so I'll keep going if that's okay, Sarah. About sort of CDK4 and 6 inhibitors, and there is an evolving evidence base around them. How does the audit respond to that when results are coming, further analyses are coming? Where do you see that indicator in particular?
So, I mean, this is our first annual report and the first time we've had a chance to look into this data and the use of the CDK4/6 inhibitors nationally. It is both the CDK4/6 inhibitors and the HER2 sort of anti-HER2 targeted therapies are areas we would like to explore further. I think further years apply that sort of show us the trends of their use, as well as being able to break this down further, but into sort of patient subgroups would be further useful analysis that we would like to do in the future.
But there is a question that's come up in different guises around, well, you're reporting the data and you're auditing. How is that going to result in action further down? I mean, it's multifaceted, but can you give some immediate responses to that in terms of how trusts can be supported to manage these pathways or improve?
Do you mean in relation to those the CDK4/6?
No, sorry, just more generally. Yeah, more generally in terms of the reports. We've talked about a number of people being discussed at the metastatic patients being discussed, allocation to treatment. Where does the audit stand in terms of supporting those pathways?
I mean, absolutely. I suppose that's a challenge of all national audits, that we have access to this huge volume of data, and we've taken that first step in producing these first annual reports. But it's important to us as a audit project team that, and within NATCAN more widely, that the findings are taken forward and do go on to produce changes and enhance patient care. So I suppose an example of how we've done that within the breast cancer audits already is producing that recurrence guideline in collaboration with COSD, because if these patients aren't recorded, if we don't know about them, then that limits our ability to audit them and and sort of improve their care. But then more widely, the audit will be being involved in quality improvement. We will be running a workshop in due course, and there's sort of ongoing engagement with our charity stakeholders, as well as individual trusts, to try and promote quality improvement. But an action that all trusts can take right away actually is engaging with our local action plan that's on the website, and that breaks down our recommendations and helps trusts examine perhaps where their practice and where changes can be made locally.
Thanks, Sarah. So there's the local action plan, there's the workshops that you're intending to do, there's local trusts engaging with NAoMe specifically. There's a very good question, though, around a paradigm shift in how breast cancer is managed, and I think probably this audit reflects that. Is there a scope or thoughts around, or evidence of, metastatic breast cancer clinics having been set up not clinics, sorry, MDTs, specifically for this patient cohort to discuss their cases at the time of recurrence or primary diagnosis?
So I suppose that's something that that's data that we haven't had access to specifically, in that we know that a patient has, we can see that a patient is recorded to have been discussed at an MDT, or we know that they've been recorded to have engaged with a clinical nurse specialist. But what is missing from the routine data at the moment is whether that is a metastatic specific MDT or clinical nurse specialist. That's certainly of interest to us as an audit, and I know it is to our stakeholders as well. So it is something that, if it becomes available in the future, we would like to analyse it and sort of and break it down more granularly.
Probably people would be interested for those examples that do exist, how that's set up, how frequently they work, who's involved, because I suppose that can be part of an implementation plan. So thank you for bringing that up as a question and answering that, Sarah. That's it. In terms of questions, there are more coming, so you can answer those offline, but we'll move on to the next audit if that's okay. But thank you very much, Sarah. So next have Jemma Boyle, who's going to be presenting the results from the National Audit of Primary Breast Cancer. Take it away, Jemma.
Thanks, Ajay. Good afternoon, everybody. I'm Jemma Boyle. I currently work as a breast registrar in London, alongside my role as a clinical research fellow on the breast audits. I'm going to be sharing some of the key findings and associated recommendations from the first annual report for the National Audit of Primary Breast Cancer, or NAoPri. Next slide, please. Firstly, to highlight, as all the other audits have, this is a multidisciplinary team effort with the names and faces of the rest of the project team shown on the slide. Next slide, please. Some of you here might be familiar with the National Audit of Breast Cancer in Older Patients, or the NABCOP, which ran from 2016 through to 2022. The NAoPri builds on the work of the NABCOP, having expanded to include all patients with primary breast cancer. This means that women under 50 years of age and men with breast cancer are reported on for the first time. Very mindful that the challenge of national audits is to try to enhance patient outcomes. Next slide, please. This report includes over 130,000 patients with primary breast cancer. Click, please. This large number makes it a powerful audit, with the cohort accumulated over a 3-year period from 2019 through to 2021. This is the most up-to-date gold standard data that was available to us at the time of conducting work on the report. This cohort also includes over 900 men with breast cancer. Click. In the bottom left-hand corner, we can see that most people included in the report have early invasive breast cancer, that is stages 1 through to stage 3A disease. We can also see in the bottom right-hand corner that a sizable number present with locally advanced breast cancer without distant metastases. This is also an important group who have not previously received much attention. Next slide, please. A very prominent theme in our first report is data completeness, or more accurately, data incompleteness. This is important because it has ramifications for what can be examined and the confidence that we have in our findings. This first graph shows data completeness for key patient and tumour characteristics for people with invasive breast cancer. The blue bars show data completeness for England, and the pink bars show data completeness for Wales. The aspiration for these key data items is 90%, which is shown by the bold black line. Click, please. You can see that performance status is not very well completed for either country, but particularly for Wales. And yet this is important when trying to understand which treatments patients receive. Similarly, ER status is fundamental to understanding which treatments breast cancer patients should be offered, but a third of people in England do not have this information returned, and yet Wales have managed to return 93% of their data. Click. At the bottom of the graph, you can see that data returns for tumour grade are excellent. We would like to better understand why this data item is so complete and how this success can be replicated for the other important data items. As an audit, we would like to do more than highlight data completeness issues, so we're keen to be active in understanding the background to data incompleteness, and will investigate whether breast units experience specific glitches or obstacles in their ability to return their data. Click, please. We therefore ask that each breast MDT has a named individual, preferably a clinician, who takes responsibility and ownership for ensuring high quality data submission. Next slide, please. The next area of data completeness we're going to look at is clinical nurse specialist or CNS contact at diagnosis. This graph, taken from our data viewer, which accompanies the report, shows the percentage of people who have complete data for contact with a CNS at diagnosis. As background, we would expect that 100% of patients do have this contact. We cannot currently confirm that with the data available. We're aware that CNSs tend to be meticulous in their recording of information, so we're keen to explore where the difficulties are in the data returns process. Click, please. On the right side of the graph, the black diamond represents the breast unit which has been selected within the data viewer. The dots on the right of the graph then represent other units within the same cancer alliance as the selected breast unit. This allows comparison of the individual breast unit and cancer alliance as a whole to national results on the left side of the graph. It also facilitates comparison of the individual breast units to colleagues within the same cancer alliance. And this information allows us to use an approach to both individual units and cancer alliances to better understand and target variation in performance. Click, please. It's important to note that these specific data items, such as CNS, which directly correspond to key performance indicators, and we encourage units to record these in the data sets. Next slide, please. The performance of all of the investigations necessary to reach a diagnosis of breast cancer at the initial consultation was something that marked breast cancer out as being different to all other cancers when it was first introduced and became known as the one-stop clinic. We were therefore very surprised when we were doing our NABCOP work that this triple diagnostic assessment, or so-called TDA, was not recorded in national data for England, despite being one of the few existing quality standards from NICE for breast cancer. In collaboration with NDRS colleagues, a data item was created which now exists in COSD version 9. In the absence of a direct data item for England, we've constructed an algorithm using other pieces of information, which can give us a feel for the performance of TDA by different units. This is what is presented on this graph, and you can see that there is considerable variation between different breast units. Click, please. We hope to progress our understanding of TDA performance, and we're very involved in trying to publicise the existence of the COSD data item and ask units to look into how best this can be completed. Next slide, please. This next graph builds on work from the NABCOP and shows that most patients with primary breast cancer have their cancer removed by surgery. It also suggests the data is of high quality with minimal variation across units. This reflects that surgical data is well recorded in the inpatient data sets, HES or hospital admissions statistics for England and PEDI for Wales, and shows that it is possible to have high quality informative data. This also highlights an area where detailed information about patient and tumour characteristics has enabled more meaningful analysis. Click, please. If we look at the graph on the left for ER negative patients and look at the blue line, which represents the more fit patients, the vast majority receive surgery, with little reduction in surgery with increasing age. In contrast, if we look at the graph on the right, again, looking initially at the blue line, we can see from roughly 70 years of age, there is a marked decrease in the percentage of patients with ER-positive breast cancer who receive an operation. There's nothing to suggest that patients with ER-negative disease are fitter than those with ER-positive disease, and yet they're being approached differently from a surgical perspective. This reflects a situation where patients with ER-positive cancer can receive hormone tablets, and the graph seems to demonstrate that this has been used by many units to allow omission of surgery. Best practice would say there is extra benefit for patients with ER-positive cancers from having surgery, as well as having hormone tablets. Click, please. This highlights the importance of an objective assessment of patients' fitness rather than relying on chronological age alone. We plan to analyse surgical care in greater detail in subsequent reports. Next slide, please. It became apparent to us that any discussion of care of older patients is enhanced with information about individual patient fitness and cognitive function. Click, please. In NABCOP, we developed this pragmatic single A4 side to aid capture and discussion of this information. Click, please. Again, following discussion with NDRS colleagues, these fitness assessment scores can now be entered in COSD returns, and we would really encourage units to do this and help us capture this information so that we can better understand the fitness of the patients. Next slide, please. The next key area of focus is that guidelines state that patients should be offered reconstruction after mastectomy and have access to this. However, these valuable pieces of information are not available in national data sets. What can be done is to show the percentages of patients in different units who receive an immediate reconstruction following a mastectomy, and that is what is shown on this graph. These risk-adjusted results are presented in a funnel plot. Each blue dot represents one breast unit. The horizontal axis represents the number of patients at each unit, and the vertical axis represents the percentage of patients having an immediate reconstruction. The red line is the average for England and Wales. Breast units lying outside of the dashed and solid blue lines are performing at least one standard deviation above or below the average national performance. And there are far more breast units outside these lines than we would expect due to chance alone. There is also no clear volume outcome relationship demonstrated, e.g. the higher volume units towards the right of the screen do not appear to do any better. Click, please. It is unlikely that patient choice alone accounts for this variation. It is more likely that this is due to factors relating to the availability of breast reconstruction resources and how this offer is made to the patients. Next slide, please. The graph shows that immediate reconstruction was more likely for patients with non-invasive disease and those with smaller breast cancers. This is likely to reflect that these patients have a less complicated treatment pathway with less intrusive adjuvant therapies and may be a good group to focus on to allow fairer comparisons between units. Next slide, please. Finally, we looked at the use of neoadjuvant chemotherapy. This is the first time that the audit has reported on this indicator, and therefore we are treading carefully in our interpretation of the findings. These results are also presented in a funnel plot, and again, there are far more breast units outside the funnel plot lines than we would expect due to chance alone. This indicator nicely demonstrates how synthesizing information from a number of different national data sets, including the SACT chemotherapy dataset, allows evaluation of clinically meaningful questions. We're progressing to analyse this item in greater detail according to factors that influence choice of treatment, such as hormone receptor status and age. Click, please. Again, we would encourage individual units and cancer alliances to look at their results using our data viewer. Next slide, please. So to summarise, the key recommendations from the report focus on improving data completeness and quality. Naturally, as people conducting an audit, we would like all of the data to be complete. However, we do live in the real world and we're highlighting areas where we'd particularly value improved performance. We want to understand where problems are arising in the data pathway in order to remedy them, and we're keen to work with people to try to get the most meaningful information on aspects of care and performance that are valued. In this first annual report, we've also highlighted specific recommendations on review of practice to be undertaken by individual breast units and cancer alliances. Next slide, please. This is the first annual report, and we're excited by the possibilities that exist in understanding patient care and specifically the variation in the care received. Please do use this link to access all of our resources, including the data viewer, and for patients, there will be a patient version of the report coming later this month. We're aware that we sometimes bombard with links, so if you Google NATCAN primary breast report, that will also take you to the correct page. Next slide, please. We always value any feedback and interaction with the audit. Thank you for listening, and I'm happy to take any questions.
Terrific. Thanks very much, Jemma. So obviously, you can see from the primary breast cancer audit that it's built on the previous breast cancer audit in older persons, which has really helped with regards to the frailty index and other evaluations. Can I just ask though, I mean, it was very interesting to see that data around primary breast resection and the drop-off in rates between ER negative and ER positive. Is there anything related to the pandemic period, or do you think that's going to be a general trend pre and post?
Yeah, good point. So this data does cover the COVID period. So some of that data will be atypical, but we saw this pattern pre-COVID as well. So I don't believe that this is explained by the pandemic. This is likely to be an ongoing trend.
And do you think the drop-offs, because the drop-offs isn't just in over 70s, which we've seen a number of audits, it's quite marked from about 55 to 60. Are there any thoughts regarding that? There's no obvious factors in terms of fitness or any other factors of that cohort why this might be happening?
So it appears as though the main reason is because there is this alternative treatment, and these patients are being given the hormone therapy as preference rather than surgery, whereas the ER negative patients don't have that option. So it feels like that is swaying people's decisions perhaps to use the hormone treatment rather than offering certain individuals surgery, perhaps based on age and comorbidities primarily.
And will you be publishing that as an indicator for an outlier process to look at trusts who have got particularly low levels of treatment in specific age groups?
So the proportion of patients having surgery is an indicator. We've not spoken about breaking that down necessarily by age and comorbidity, but that is something that I could take back to the team.
I think with all these data items and as the performance indicators mature, that those specific questions as to how to improve, it's one angle. And you mentioned around the triple diagnostic assessment and an algorithm that you developed. Can you talk a bit more about that, please?
Yeah, so the problem with England is that there wasn't originally a TDA data item, and it was only when we started NABCOP that prompted us to realise that that was the case. So at the moment for England, we're not getting any data back on the specific TDA data item, which I listed on the slide. So that means that we have to try and get that information from elsewhere. So at the moment, we're using dates of diagnosis and biopsy dates to try and use that as to work out whether or not people have had TDA, which is obviously not a perfect way of doing it. Wales actually have their own data item, and that is being better completed. So this is certainly an area that we particularly want to focus on, and we are in the process of setting up a working group specifically to try and unpick how we can better look at the use of TDA and report that as accurately as possible.
Mastectomy and reconstruction has come up. I mean, it's been mentioned for a while now. I think probably even in the 2000s and 2010s regarding access to it. It's now in guidelines. Is there any recommendations or advice or evidence of good practice, or where it's been organized well and patients get a opportunity to speak to people with the relevant expertise? Or is this around not expertise, it's patient choice or the assessment? What are the factors that people can take back to actually see what can be resolved?
So I guess I can answer this from my own clinical perspective. So at the trust that I work in, we have very ready access to the plastics team, and we have a direct link there whereby patients can be referred, discussed in an oncoplastic MDT, and they have very ready access to that resource. I understand that is not what happens in every hospital. So I guess that would be an example of good practice and something that other hospitals might be able to replicate if possible.
Thanks, Jemma. There's a couple of questions that have come through that I could probably answer. So one of the questions has been, there are across the 6 audits and even other 4 established audits, questions around data quality, completeness, and absolutely within NATCAN and our relationship with NDRS and other providers, we will be working towards improving that. There's specific questions around whether it relates to their electronic health records. I think it's multifactorial. I think first and foremost, the reason why we're publishing the data, particularly in our quarterly reports, is to show that actually we're not where we need to be with regards to information on disease, the stage, patient's fitness, to be able to really establish variation in quality of care. So that's absolutely essential, but we are reliant on that completeness. And there's been a specific comment about who's going to fund that, where's the time going to come from, and that's an ongoing factor. I think we're all extremely stretched, but having good quality data to be able to improve quality is absolutely critical. I think we don't work by ourselves. We work in partnership with the NHS England, the integrated care boards, and actually we have in our recommendations suggested the importance of having adequate funding, but also devolving and ensuring that responsibility is taken for improving it. So I think it starts with ownership of the data, realizing where the deficits or the barriers to completion are, someone taking clinical responsibility or management responsibility, and then focusing on actually what are the levers required. Is it a case of funding? Is it a case to block out time? Because it's absolutely critical in that regard. So thank you for that question. And it is something in the recommendations that we have and the work that's being done within the alliances that this is coming up across all the audits. I think if there are not any other further questions, I think we should let you go, Jemma. But thank you very much for your presentation and answering those questions. I think it comes to me to actually close off the session. So I think the first thing to say is thank you to all the presenters. I think you can see that there's some very interesting results coming. There's work to be done, but this is the first audit, and it can take 2-3 years to really harness those performance indicators and to deliver action. And it's partly trying to understand what are the factors underlying it. Next slide, please. So I think there are a few points I wanted to make. So first of all, there's not a one-size-fits-all approach. You can see with each of these audits, they're very, very different questions being asked. There's not a cancer issue per se, but each of these pathways of care, diagnostic, treatment, survivorship, workforce, data, allocation to treatment, they're all extremely specific to the audit. So we are dealing with something that's high in complexity, and we need to appreciate that when trying to improve quality. There's still a continued issue with what I described as the fidelity of care, and that's, we have evidence-based guidelines. We spend considerable sums of money on research and development, and those guidelines and recommendations and treatments with a strong evidence base aren't necessarily being received by the people who require it. And there is potential variation across hospitals in that regard. We've also seen there's still a clear need to improve treatment timeliness. I think we're all aware of that working within the NHS, that we need to do better, and it is high on the agenda, but actually there are still people waiting far too long for many of the evidence-based treatments they require, particularly for those which have poor prognosis. What I found interesting personally, and many of you potentially, is that I think if we look at the UK or the NHS as a whole, we have been the front runners for the role of the MDT and that integration. I think the NHS has been integral to achieving that. But we're still seeing now with the newer audits that actually not necessarily everyone is getting the specialist opinion they require or discussion at the MDT. I think that in part is probably related to the increasing complexity of the service that we have. As we mentioned, one of the questions around the metastatic breast cancer audit, is there a question about having a specific metastatic breast MDT, but obviously that requires resourcing to achieve that. Next slide, please. I think some of the results were quite sobering, particularly in survival rates. I think the pancreatic cancer audit, 4 out of 5 patients diagnosed with pancreatic cancer don't live beyond 12 months. But I think really what the audits are trying to do is both present those results, but the variation in it. And as we get better with the risk adjustment and also targeting particular centres where there is variation performance, we really need to improve that overall. The themes that are coming out across many of the audits as well is that the management of older patients with cancer is a common theme. Does that relate to understanding of comorbidities? Is it about the adjustment that we do for frailty? We now have a frailty score. We really need to unpick this. This is the same for whether it's the bowel cancer audit, the prostate cancer audit, and lung cancer audit. This will keep coming up, that the management or the variation in care, if you look in the under 60s, is actually relatively limited, but as you get over 70, where you are managed in the country is very different in that age group. And we need to understand what are good practices of care. Is it oncogeriatrics? Is it the assessment of those patients within those clinics that's different? And having the relative resource. I think the third factor is that practice is evolving, and we have got some standards that are there that we can publish audit results for as well as outcomes. But we also have some evolving treatments where there really does need to get the clinical communities, professional bodies and societies together to understand what truly is a standard of care. So there was the mastectomy and immediate reconstruction, which is now sort of in the guideline, but there are additional questions regarding, do patients with a recurrence need another biopsy, the role of neoadjuvant chemotherapy in primary breast cancer. There are other questions in terms of non-Hodgkin's lymphoma. So we really need to, as part of this, try and guide what the audit can do so that we avoid that patients having treatments that are completely different in one part of the country compared to another. Finally, I think it goes without saying, data has come up repeatedly. It has come up repeatedly. We do need to complete those items just in terms of the disease, the treatment, and the fitness. As I said, it's a recommendation across all the audits. We were also reliant with our partners in NHS England, but we need to get the ownership within the actual MDTs and the centres themselves that this is an important issue and work with them to achieve that. And we'll continue to report what the data completion is, so local quality improvement can be reviewed in that lens to see how those factors are improving in terms of recording. Next slide, please. So we want to move from data to impact. We can produce this data, but how do we go further? As I've mentioned, we've created recommendations, and those have been done and developed in combination with our clinical reference groups and also our patient and carer forums. And these are recommendations at the Alliance, Integrated Care Board and national level, but it does need trust to use the information to understand what the drivers of quality deficits are. I know it requires time, I know it requires resourcing, but quality is integral to what we do. I feel that there is a lot of discussion around having new innovation, machines, drug therapies, but actually it's fundamental that we do focus on variation in care and quality, and we need clinical champions for that. In terms of what we're doing from NATCAN and what we can do as a body, which is primarily around quality assessment and assurance, is we have developed quality improvement plans, which were published in September. We now have moved to 3-monthly reporting for some of our clinical outcomes, and that started in October 2024. And we'll have these interactive dashboards in January, particularly looking at time series, which many people mentioned. A big thing is that one of the performance indicators for each of the 10 audits will now form a quality improvement initiative, which will also be rolled out towards the latter half of 2025. And there are many different approaches, and that can be in the way that we feed back information to more for the established audits, looking at quality improvement collaboratives, for instance. Next slide, please. I think it goes without saying, this is a team effort. We've got 10 cancer audits. Within those audits, we have some 33 clinicians, 17 academics and 6 managers. We absolutely need our clinical reference groups and patient and public forums. We have 20 charities as well, 12 professional organisations. So a real team effort, and thank you for bringing today to fruition, particularly the speakers. Next slide, please. I just want to also thank, and if they could come online, although they might be embarrassed, if Julie Nossiter, Verity Walker and Sugita Sukumar could just come online briefly, please, because they've been integral to actually delivering a fantastic webinar, which, believe it or not, is actually going to finish on time, which is an outcome in itself. Don't know if Sugi can have the camera. Thank you very much for your efforts. Again, thank you to the speakers. We also have our methodological leads or an executive on our board. So thank you for your attention today. Please send us more questions. We will endeavour to answer the questions in the Q&A, and I think the big thing is this is just the start. We intend to publish more, get better data, have more action and impact further downstream, and work with you all. So thank you for your attention today, and the very best. Thank you.